just really excited about this project and was delighted to be invited to participate and provide some insight on trauma and violence informed approaches as they relate to financial literacy education. As you can see from my bio and the sort of titles here, my area of expertise has been violence against women, gender-based violence, in particular intimate partner violence, as well as a focus on health equity. So as we go through this, I might tell you a little bit of my journey of how I got to being an IPV researcher to doing work on trauma and violence informed approaches. So I would like to start by acknowledging that I sit on the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Chinook nations in what is now called London, Ontario. And I do pay my respects to elders past and present and convey my sincere gratitude for the privilege to live and work on this land. And as I've worked with elders in different projects in our equity work, they always ask me to add a personal note. What does it mean to me? What does it mean to actually acknowledge the land and the long-term presence of Indigenous people? And in my research, which does deal with difficult issues, and I would encourage everyone as we move through some of the content to take care of yourselves, to leave if you need to, mute and so on, is as we look at groups that are especially marginalized and impacted by certain issues, we have to be very careful in not reinforcing stereotypes or biases. And as we go through the material, hopefully you'll see that the way that we use language in a TVIA approach and the way we talk about and with different groups, especially Indigenous people in this country, needs to be done in a respectful and careful way. So in my work, I prioritize not using data or not allowing the data that I collect to be used in ways that might re-marginalize and reinforce stereotypes around Indigenous people. So that's my personal acknowledgement. These are the learning objectives. As Rebecca mentioned, this is the first of 4 webinars, which I'm excited about actually, because I don't have to try to cram everything into one. So this is sort of a high-level overview of what we mean by TVIA. And at some points you might hear me say TVIC, or some of the graphics might say TVIC. Because I've worked a lot in the area of healthcare and social services, we use the word trauma and violence informed care, but it's part and parcel, it's the same. And we've done research and implementation work in many different sectors. On Friday, I'm talking to a surgical audience. A couple of weeks ago, it was a settlement service audience. So I'm not an expert in financial literacy. You are the experts in financial literacy. So we are together going to co-create what it means to be trauma and violence informed in providing financial literacy education. So hopefully by the end of this, you'll have an overview. And as you come back, and I encourage you to come back for future seminars, we will start to develop specific instances and strategies that reflect the 4 principles of TVIC and how they can be applied to financial literacy education. At the end, I will also provide you with, of course, some links to additional resources, and we do have a lot of them. So I just want to start with a little scenario, and I just want you to reflect on this. We're going to come back at the end. So you've just started working with Elaine, a woman who came to you through a referral from a local domestic violence service. She comes to the first session late with no apology or explanation and doesn't seem to take in a thing that you say. When she leaves, you're a bit frustrated. You call her later and you leave a message with the time of your next session. And this could be an individual or group session, doesn't really matter, but you never hear back. The session times arrive, but she doesn't show up. So that might be a common scenario in your practice. I certainly use this one with public health nurses, and they often find that this sort of thing can happen, and it can cause some frustration as a provider who's trying to help folks. So maybe just give some thought to that, put it in the back of your mind, and at the end we'll come back to it. So I had to do my own research because I'm not an expert on financial literacy or education in this space. And I looked through some of the Families Canada resources on financial literacy and some of the programs and online learning that they have. And I was trying to find that alignment. As I said, I think trauma and violence informed approaches really integrate well. I've mentioned a couple of the areas we've worked in. We've even worked with police services here in London, Ontario, and emergency departments in BC. So these approaches do integrate well, even when you might not think they do. And I certainly think, given the types of programming that Families Canada and some of the related organizations that you all represent there is a very clear link to me in terms of that community-based service to really support women and families and people in gaining that financial literacy to overcome some of the barriers that they're facing. So I think that it aligns well. I'd love to hear what others think by the time we get through this. The first thing I always acknowledge when doing a workshop like this or a webinar like this is that our work doesn't always feel good. And, that can be because we are actually not able to reconcile the way that we are forced to work in systems or structures or conditions that might not align with the values that we bring to the work. And as I say, I've worked a lot with the health and social service sector. Most of us don't go into this work because we want to do harm. We actually want to help. We want to support people. Certainly in many of the professions with which I work, people are not extremely well paid, so they're not in it for the money, they're in it to help. Sometimes, however, the programs or organizations or even the whole system, right now the health system in Ontario is a good example, is just set up in a way that actually doesn't let you do the work in the way that you want to do. And these mismatches can be called emotional labor, sort of the extra work to do to get yourself motivated. But when those mismatches become really severe, and if those mismatches mean that our clients are not as well served as they could be, or even potentially harmed when receiving service, it can escalate to what we call moral distress. And we've heard a little bit more about this in the media lately, because certainly nurses in Ontario and across Canada and even internationally are definitely feeling that moral distress of not being able to provide the care that they want to under current circumstances exacerbated by COVID. So really this points to the need not only to support individuals in their practice, but for organizations to step up and make sure that their providers, their staff, are safe and well. And that really means looking at organizational culture. So one of the key things, and giving away the ending, one of the key things that we really want to emphasize when we go through a TVIA approach is that individual strategies for shifting your practice must be supported by organizational policies and protocols and really culture that provides and enables and supports individuals to do the work in these new ways. And if we don't have that, that's another mismatch, and that can actually exacerbate moral distress and burnout and loss of staff and those sorts of things. So really, staff wellness is a core piece of a TVI approach. And this distress can happen within people, but in a team or a unit or a whole organization and beyond. So, and I think what we're seeing through COVID is this distress sort of permeating out. So another point for this slide is you're not alone if you're feeling some of these things. And it's important to acknowledge that you're not alone and acknowledge that these feelings are actually quite understandable. So now it's time to start to think about ways to fix them. So what does it mean to be trauma-informed? Because I want to start with trauma-informed approaches, and then really move us through to why adding the V and being trauma and violence-informed is important. So trauma, and many of you may know this, so this is just a brief overview, is the experience of, and importantly, the response to a negative event or series of events that can threaten our safety, our life, or our integrity, bodily, mental, psychological, and so on, and overwhelms our ability to cope. So this is more than everyday stress, okay? And everyday stressors, and you might hear literature or just sort of common talk that, we need to stretch ourselves. We need to feel a little bit stressed and disrupted for good change to happen. This is beyond that. This is in that space where we feel our safety is at risk. And that's when we get into the space of post-traumatic stress. And I think an important reframe, and again, we've evaluated these sorts of webinars and the workshops that we do, is to start to think of post-traumatic stress as an anticipated response. And then some of the things that you might be seeing in your practice are not necessarily predictable, but they shouldn't be a surprise, because we always have to remember that many, if not most people, survive and thrive. They find ways to overcome these traumatic exposures, but that will vary, and it varies according to a lot of different factors, and we'll go through some of these in a moment. So the traumatic stresses that we experience can be acute, so resulting from a single event, or chronic and complex. And I think that's where, again, sort of bringing in a V becomes important in that new lens. Trauma is very common. So this is actually a map, you don't have to read it all, but from the World Mental Health Survey a few years ago. Canada wasn't included in the World Mental Health Survey, but similar work done in Canada basically shows that we'd also be in the red zone here. So about 3/4 of Canadian adults would meet the threshold of traumatic experiences for post-traumatic stress. So the important thing here is most of us have experienced one or more forms of trauma and or are surrounded by people who have experienced those forms of trauma. And I think the important point here is trauma is so common that we need to start thinking of universal strategies instead of targeted strategies to not further perpetuate trauma or to activate trauma in those that we serve. And that's where sort of this trauma-informed approach comes in. So here are some examples of traumatic experiences. We mentioned COVID and what we've been living through, and now the sort of fallout from all of that as a collective trauma. I've highlighted a few things here, in terms of the women that you might be serving, the families you might be serving, but I also want to make the point that these are very interrelated, okay? So this is where the idea of complexity comes in. So if you're experiencing trauma, especially in earlier stages of your life, so adverse childhood experiences, or ACEs is one term that's been used, you're actually more likely to experience forms of trauma later in life, including violence and victimization, but also poverty, developmental challenges, low educational attainment, etc. So these things sort of perpetuate one another in some cases. And if you're living in the context, for example, as an Indigenous person, of having a history in your family or your own life of residential schools, and the ongoing effects of colonialism, the Indian Act, literally policy that's sort of built in to make the lives of Indigenous people extremely difficult in this country, then that context, that setting, and that, that you're living in will be interrelated with how you experience these traumas, but also your likelihood of experiencing these traumas and your ability to seek help or find help when you're experiencing these traumas. So you start to see that, it's a complex web of different interactions that might be happening here. And that, again, it's not up to you to untangle the web. It's up to you to understand that what you're seeing when you're interacting with people might be due to a whole bunch of stuff going on. You don't have to go digging for it to find out exactly what it is, but you can change your practice in ways that will better support those that you're serving and ultimately lead to better outcomes in terms of that service that you're providing. Oops. So I think an important point here, and this is not my area of expertise, I'm not a neuroscientist, but the idea that trauma and traumatic stress actually impacts your brain and your physiology. So, they talk about this adrenaline response, let's say, or stress hormones like cortisol. And if you're experiencing a sort of acute traumatic event, you can imagine you feel that sort of rush of adrenaline, and your first instinct is to protect yourself. When you're experiencing complex chronic forms of trauma, this is happening so much that it's actually difficult for you to re-regulate your brain. So you're in the constant state of having, I use the analogy of your brain sort of swimming in these stress hormones and your body responding to that in ways that, can feel like a panic attack, for example. But again, different people will express and experience these in different ways. The point being is this is about your body as well as your mind and your brain. And we need to sort of understand that what we see in front of us can't necessarily be helped by people. So, one of our key points here is not to judge and not to blame. If we understand that these responses are part of a physiological, survival instinct, that might help us, be a little bit more kind and compassionate when people are going through this. So being trauma-informed means recognizing that these forms of stress are common and they affect how people think, feel, and behave. So there are sort of a few examples here of what this means and what this can look like. At the bottom here, I have the fight, flight, freeze, fawn, little box there, because that's often how people think of it. So when you're in that sort of stressful, threatening situation, you feel that rush and you might want to fight back. You might become defensive, you might leave, just get out of the scenario, or you might try to ingratiate yourself and make sure that you're not going to be harmed through that process. And it will look different. And if I think of my own responses where I've had threat and sort of just feeling like I need to protect myself, sometimes it's one thing, sometimes it's another. Okay, so it can look like dissociation or numbing, people just tuning out and not really hearing what you say, and you're wondering, are they even paying attention to me? Why am I bothering, to actually talk to this person? Or they can be hyper-vigilant and monitoring everything that's going on in their environment. So both of those things can be a stress response. And it's important, I think, as a provider to sort of understand what you're seeing and what it might represent. I think the other point here, when I talk to healthcare audiences, I say, look, there's this list of healthcare issues of physical and mental health issues that are related to these exposures, including chronic pain. So when people are talking about these symptoms, you might start to think about, is this related to experiences of trauma and violence? And then importantly, I think the issue of how people might behave. So the point I make here and why substance use is highlighted, when you've experienced a lot of physical, emotional, psychological pain, you want to numb that pain. You don't want to feel that pain. So we talk about the link between chronic pain and substance use, and maybe reframing what is often a very judgmental response to how people use substances to a more compassionate response about why and how people use substances. So on the next slide, and I don't have time to go through all of this, but this is something that we've used in a forthcoming handbook that we've created. And we also have developed a whole curriculum on this because it's so important for healthcare providers and others, serving those in the community to understand some people are stigmatized, some substances are stigmatized. Some people are stigmatized for using substances even when they don't use substances. And here I use the very tragic example of Mr. Brian Sinclair, who visited an emergency room in Winnipeg a number of years ago. And because he was Indigenous, the staff assumed that he was drunk. He actually did not use alcohol in his life. He was not a drinker. So they left him. They left him sitting in the emergency department for almost 2 days. And when somebody finally bothered to check on him, he had passed away. There was an inquiry into this. And basically the result was that racism, killed Mr. Brian Sinclair. And we have other cases of this, Joyce Echaquan in Quebec. And this is where, the intersection of a person being stigmatized or, basically racism against certain groups and people intersects with certain substances being stigmatized. And if we think, in our broader community and the rates of illicit substance use and toxic drug overdoses, we are not responding to that crisis in the ways that we could because those substances are stigmatized. And then on top of that, the people who use them are stigmatized. And all of this actually fundamentally is often related to chronic pain because of trauma and violence experiences. So more complexity here. And again, it's not up to us to be experts in all of this. It's up to us to help make those connections and think about how our own approaches as individuals and organizations might be further stigmatizing people and to work against those potential biases to not stigmatize people and provide better care. So as I mentioned, there's a lot of complexity here. What you might see in terms of people's trauma experiences does reorganize their brains, their physiological responses, in some ways their ability to express their genes. So you get the concept of epigenetics. The earlier and more often these things happen, the more complex it is, the worse it can be. But people have protective factors and people can survive and thrive. So we have to look beyond the individual to their family environment, their community environment, and again, increase the protective factors in those environments to support people when they are seeking help. And an important point here to also mention the issue of vicarious trauma, because when you are, as a provider, hearing these stories, and they're getting worse. I mean, let's face it, COVID has made things worse and also revealed a lot of things. It's hard to hear these stories over and over again. So as a provider, you might be experiencing people's trauma vicariously and hearing a lot of pretty horrific things that can then start to actually articulate themselves as a trauma response in your own self. And those symptoms often mirror the things that I just went through, the fight, flight, freeze, fawn. Your sleep might be disrupted because you're thinking about something horrible that you heard today at work. And we need to, recognize and address this. And again, reinforcing the need for organizations to step up. We need the education, but we also need organizational strategies to make sure that staff are well. And that can include things like carefully constructed opportunities for debriefing, formal or informal, but really led by the person. Because you don't want to force people to talk about things that they're not ready to talk about. So it can't be, everyone, has to tell everything that happened today that upset them. If that's not where the person's at, you can do more harm than good. And I think there's evidence emerging around that. And things like reflective supervision, that that there's somebody, a supervisor you can go to that will be able to say, okay, we have an employee assistance program, or we've got these other organizational supports built in to make sure that you are taking care of yourself. And I think one of the things we're seeing with many, health and social service providers leaving their professions right now is organizations and systems haven't really stepped up to make sure that people are well. And now we have a crisis because we don't have enough nurses, and we have physicians burning out and community workers burning out. I work a lot with the women's shelter sector, and it's bad over there, as many of you probably know. So at the bottom here is a link to a tool, but at the end, I'll give you sort of the links to the different tools and resources that we've created. So I want to differentiate when we're talking about TVIA or TVIC approaches, or even TIC, we're not talking about trauma-specific care. That's specialized services by, psychologists or counselors or psychiatrists who know how to actually treat trauma. So we're not saying everybody needs to become a clinical psychologist to be able to interact with people in a TVI way. So let's put that aside. Trauma-informed, is important because it gets at these points I've just mentioned. A universal approach, because trauma is so prevalent. Understanding what trauma can look like and how it impacts people, especially so that we're not reactivating people's trauma. So that things that we're doing in our environment, whether it's in a program or a setting or one-on-one interaction, are safe for people, that they don't feel that trauma is being triggered, so to speak. As a violence researcher, I'm not a big fan of the word triggered, but people seem to like it. Reactivated is the term that I use. I think the problem, and those of us who've been doing research in this area, is sometimes we tend to focus on, the fact that the trauma exists in the minds of people and is in the past. So we say, well, something happened to that person, there's something wrong with that person, so now we have to make sure we don't make that worse. And that's where I think, we found the limits of a trauma-informed approach and wanted to start adding the V. So the V does two things. And again, maybe it's because several of us who started this work were violence researchers. We want to focus on interpersonal violence as a unique type of trauma. So we mentioned, situational traumas and so on. So what we're saying here is that having experienced child maltreatment or intimate partner violence and still experiencing the effects of those things is different than being in a car accident. Not to say that being in a car accident is not traumatic, but this is a different scenario. And the main reason is that these are often chronic and ongoing types of abuse. So it's not a one-off. It can happen often. And in fact, you're in a daily sort of situation where you're living in this fear. And especially when it happens in childhood, it is a violation of trust and really alters our ability to form attachments, safe, meaningful, important attachments with people. And that is a different level of impact than a random accident or a natural disaster. So we also talk about the fact that these experiences can become intergenerational. And there certainly is a lot of research showing that if you've experienced violence in your childhood and been exposed to violence in your family between your parents, for example, or caregivers, you are more likely to grow up to both perpetrate and experience or be a survivor of those forms of violence in your family. So you live what you learn. So it's really important to disrupt those cycles of violence. And again, if we start thinking more structurally, we can see that certain groups are differentially impacted because of policies and the way that we organize society. So the experiences are gendered. Again, as somebody with a title that says, gender-based violence, I always have to look at gender. And social norms about gender really drive a lot of this. We tend in our society to, not only glorify violence, but we enable it in many ways. We exonerate perpetrators, we blame victims. In the context of sexual violence and intimate partner violence, women are the primary victims, men are the primary perpetrators. But if we look more broadly, men are the primary victims and perpetrators of violence writ large. And, even these gender norms, the dynamics of gender norms mean that men are less likely to seek help when they themselves are victims of violence, outside or even within relationships. And the fact that men don't seek help, I think, linking back to a couple of points I made earlier, we're talking now about deaths of despair. I don't know if you've heard that term, but deaths by suicide and deaths by drug overdose, often from illicit toxic drug supplies. Those are more likely to occur in men. So if we have norms that mean that men are supposed to always be strong and not seek help, but they've experienced a lot of trauma and violence and ongoing violence, they are seeking, solutions that are extremely damaging to them. So I think the gender, obviously I'm a feminist researcher, I do gender-based violence, violence against women. But I think we have to move beyond, individual level thinking to be able to start to solve these problems. And that's why I really like trauma and violence informed approaches. So again, this cross cuts all groups, but as we've talked about, the risks are more likely to occur in other groups, and that is because issues of structural violence. So, very briefly, structural violence is basically the way that we have structured and organized our world. That could be at the policy level. I mentioned before the Indian Act as an extreme form of structural violence and even genocide. But we also, in our organizational policies and protocols, might have things that, intentionally or unintentionally discriminate against certain groups or people. And it might be that you say, I just want to make sure everybody in my shelter is safe. So we're not going to let anybody in if they're actively using any substances or if they might be in mental health distress. So then what happens to those people who are unable to access shelter because of policies like that? So I think, we need to examine beyond the individual level, what's going on in our policies and our protocols and our organizational culture that might be adding to these forms of harm that people are experiencing. Certainly things like minimum wage legislation is a form of structural violence. That'll be an issue with those, the women that you're serving who are living on low income. And, rhetoric like, well, they just need to work harder and pull themselves up by their bootstraps is extremely unhelpful when you have a minimum wage that doesn't actually let you, live. And you can work 3 jobs and still actually not have enough money to live. So I think when we are interacting with women who are living in poverty, it's especially important for us to think about all of these different things that have not only happened, but are still happening and are well beyond an individual's control. And again, that can lead us to a place of compassion rather than judgment, and thinking about, for example, what options are available to people and really being intentional about planning options for people. And we'll talk about that in one of the principles. And I also like to raise at this point the notion of implicit bias. As humans, we have different strategies to help us make sense of the world. When we're taking in a lot of information, we tend to want to categorize things. We want to reflect on our previous experience or things that we've heard and think are true. And often those lead us to the place of having implicit biases or making judgments without even knowing it. And that's sort of what we mean by implicit here. So we might hold some stereotypes about groups or individuals, and we don't even know that we're applying those when we're interacting with somebody. And this middle point is research is done by a friend and colleague of mine, Javid Sakara, who's looked at healthcare providers in emergency departments. And as soon as they see somebody who's in mental health crisis, which again, emergency departments weren't designed to deal with mental health and substance use issues. They're designed, based on sort of a military medicine model, right? For physical injuries and acute sorts of injuries and heart attacks and things like that. So you've got a system that is trying to deal with something it wasn't designed to deal with. You've got individuals who are feeling quite overwhelmed and more so. And then they see somebody come in, and because they might have some stereotypes and stigmatizing beliefs about people with mental illness, they just think, I don't want to deal with this. This person is not fixable. It's not our job in the emergency department to try to fix this person, and they're being difficult. So they might avoid that person or really, in an interaction, not seem like they want to help. And whether or not, wherever that comes from, the person themselves, the service user, will perceive it as discriminatory or dismissive. Often, it's worse if they face that form of stigma and discrimination in other services. So again, thinking back to Mr. Brian Sinclair, if you're an Indigenous person, just to step foot in an emergency department and know how you might be treated, that takes a lot of guts to actually go to the emergency department. And we've done research, most folks don't want to go to the emerge. You're not having the best day when you're going to the emerge. And then you have to face this on top of the fact that you're going to the emerge because you feel really bad. So we as individuals, we can't fix all of it, but we can definitely fix that initial interaction with somebody and make them feel human and make ourselves feel more human. So that's a win-win. And make sure that we are doing everything we can to live up to our own values and our professional values and obligations. I know I sound a little preachy, sorry. So what is trauma and violence informed care, or trauma and violence informed approaches? It's basically the confluence of these things. So we want to have that knowledge of trauma and violence and what it looks like, the trauma informed stuff that I talked about before. definitely make sure not to make things worse for people during those interactions. We want to have that critical understanding of interpersonal violence as a complex chronic form of trauma and what that might look like for folks, and then the impacts of structural forms of violence. And then I think the other piece, and again, when we talk about this in our model of equity-oriented care, TVIC is one of the components. We also talk about cultural safety and that humility as a provider, and trying to really think about the power that you have and share that power so that people feel deserving and feel that there's an important next step for them. So that's sort of the TVIC model. And basically we're extending to bring attention to those broader social conditions, to think about responses to trauma, including things like substance use as anticipated responses, and switching from judgment to compassion, to shift the mindset from what's wrong with somebody to what's happened and might still be happening to somebody, and again, to address the complexity of interpersonal forms of violence. So, we want to prevent harm, we want to create safe environments, we want to do this for everybody, and we want to make sure that the accountabilities are definitely at the organizational level, and that the organization supports changes in individual provider practice. So these are the 4 principles, and they're fairly simple. And again, there's been lots of research in trauma-informed approaches, and also an evolution beyond that in some sectors to look at these principles. We've tried to simplify them. Some models have sort of 10 or 15 principles. We've simplified them down to 4, and then really tried to talk about which ones are absolutely key to make that V, big and important in terms of the work that we do. So the first one is to understand trauma and violence and its impacts on people's lives, but to really have that structural lens, and the things that we as a society have decided to do that are maybe not okay. And they're called violence because they're harmful. They're causing harm. And when we talk about creating safety, it's not just physical safety for people. Obviously, we want physical safety, we want privacy, we want to make sure that those who might be perpetrating abuse are not hearing interactions with women who are in abusive relationships, those sorts of things. But we also want to create emotional and cultural safety. And we want to actively counter discrimination and stigma. So we have to recognize that some people are not going to feel safe and welcome in our setting, in our program, in our office, by virtue of the experiences that they've had, and then go above and beyond to make those people feel safe and comfortable. We want to foster opportunities for choice, collaboration, and connection, and use a strengths-based approach. So again, these are humans. They come to us with a lot of strengths, and it's our job to identify those and build on those, while maybe teaching new skills to support specific things. So the next few minutes, I'm just going to go through at a fairly high level what these can look like. But what I'd like to sort of challenge you to do, especially those who hopefully will come back for the 2nd and 3rd and 4th webinars, is sort of think about what this looks like in financial literacy education practice, because it's not my area of expertise. I've done, I've listened to Rebecca, I've done a little bit of my own research, but these examples should cross-cut different types of programs in which you work. But I think it's important to start really developing good practices and sharing them amongst all of you so that you can build on that expertise. So the first principle in terms of understanding trauma and violence, and that focus on structural and systemic, is for the organization to look at its policies and practices, with ideally not only staff, but people who are using your services. Because folks who are using your services will be very good at telling you what's working and what isn't for them. So you'll see this sort of threaded through the different principles. But you need to make sure that, when you bring new staff on board and when you develop new policies, they're infused with a trauma and violence informed understanding. And that when you're hiring people, you're making sure it's not just about EDI, it's about really people who understand what trauma looks like in the people that they serve, or are certainly willing to learn it. And that might also include making particular staffing decisions about who runs a program. Somebody might be better suited for one type of program versus another. And this is an ongoing thing, and it's an organizational culture shift is what it is. So you want to provide training, and then you want to actually examine your services such that they start with this as a foundation. For providers, and we often say the provider is the intervention, or at least is the first instance of the intervention. So a client or service user coming to you, you're the first person they see, or it might be actually your waiting room, depending on the setup. So you want to make sure those initial interactions are safe and people feel good about those things. So as a provider, we've talked about reframing what we're seeing, and instead of judging, being compassionate. So when people are expressing what you might call challenging or non-adherent or non-compliant behaviors, I would actually get rid of all that language and just think, wow, you seem to be having, a bad day. Can you tell me what's going on? And then start from there and have a conversation. When you hear about things in that conversation, link them to those, examples or experiences of trauma or structural violence, and try to understand what's going on through that lens. And if you do hear disclosures, again, we do not advocate for routine universal screening for these experiences and digging for disclosures. But what happens is when you're a good human and you provide a safe place to have a conversation, you might often hear disclosures. And if you do, you believe, you affirm and validate. And again, you go through sort of recognizing strengths and strategies for next steps, as we'll talk about. Creating those physically, emotionally, and culturally safe environments is incredibly important. I think if you were going to do one thing as your first step, you might look at our trauma walkthrough tool. And again, I'll give you the links a little bit later. And do the walkthrough and try to experience that space as if you're it's the first time you visited it, or it could be a group setting in a community service, wherever it is that you do your work. Do that walkthrough yourself, do it with your team, and then invite folks that you're serving, especially those who might be facing barriers to service, to do that walkthrough with you. And again, that you will hear things that you might not have expected because you've been doing the work so long, you don't really see some of that stuff anymore. But people do see it, and often those things are fairly easy and cheap to change. It's not hugely expensive. It's really maybe changing some of your intake procedures or language or the way you've got the room set up. I did a workshop one time and child welfare was there, and they changed the lighting in the waiting area because institutional lighting was very triggering to people, especially Indigenous clients who'd been in residential schools. So they changed their lighting, and that really helped those clients not be reactivated, which meant a better, calmer interaction with a caseworker, which was better for everyone involved. We talked about vicarious trauma and organizations' responsibility to make sure that their staff are well, and that you think about safety. And we see more and more, whether it's a grocery store or an emergency department, there are a lot of outbursts. People are very angry and very unsettled. And, if things are escalating, you need to have a safety plan to support staff through those moments, but also to make sure that the client themselves is in a good place and has a next step, even if you can't provide it because of an escalating situation. I mentioned, attending to power differences and boundary violations. Really being clear about your role. You're not there to treat their trauma. You're there to provide your service, but you're there to do it in a way that is safe and, leads to effective outcomes for people. Talked about not being judgmental. It's also important for people to know what's coming. So especially if you've lived, with a lot of different traumatic experiences that make it really stressful for you to not know what's next. Having clear and predictable expectations about programming and providing those in clear and accessible ways is a good way to help people not get to that level of stress and uncertainty. So, and that's a fairly easy thing to do as well. So, in an individual encounter, it might be, we've got a half an hour today. Here are the things we're going to talk about. Do you have any questions before we start? That took me, 5 seconds, 6 seconds? And again, with the women you're working with, you might really think about the safety in their own relationships, given the sort of correlation between low income women who might be seeking these services and the violence that might be going on at home. The third principle is, again, around choice, collaboration, connection. I think flexibility and time use at the organizational level, or allowing the providers to use their judgment as to how to tailor a program, either in a particular interaction or a session, or overall to serve the needs of those that you're serving and trying to provide care for, is the most important organizational strategy. Really rigid systems do not work well in terms of promoting TVI and equitable approaches to service. And involve staff and clients in how to do that, because again, those closest to the work will know. Again, non-judgmental responses are important, but the key point for me here is options that you provide have to be realistic for people. you know, if somebody's on low income and you're saying, okay, well, what you really need next for your child is trauma-informed cognitive behavioral therapy. There's one person, they're on the other side of town, it takes 3 buses, and they've got a 6-month waiting list. That's not a realistic option, okay? And that's going to be basically seen as a dismissal because people are saying, well, that's not something I'm going to access. So really listen to people. What do they need? Consider choices collaboratively and educate yourself as to what's available broadly so you can actually provide a referral to something useful and something that people can access. And then being strengths-based and capacity building. So this basically means, again, for the organization, some people will need a bit more time to have that conversation for the provider to be able to identify those strengths. And then you can tailor the options to people's strengths and the areas where they might need to develop more skills. And staff themselves need to be provided with more opportunity for skills development. And listening, again, to clients is really important, acknowledging their experience. And then if you know, reasonable and appropriate, you might also have staff know how to help people calm and center themselves. And it might be mindfulness or breathing exercises that can be used during a session. So, you know, we don't have a huge amount of time. I'm watching the clock here and I see Rebecca's face. So I don't want to take too much more time. But maybe at this point, we might want to reframe the case of Elaine a little bit. And a few of the things we might want to think about using a TVI lens. So, you know, what are the impacts of structural poverty here? We know that women get paid less than men for the same work. As I mentioned before, minimum wage laws, you know, don't really allow people to earn a living wage. There could be situational poverty. Elaine, in this case, is in an abusive relationship. Once she decides to leave that relationship, which she might not decide to do, it is her choice. We often assume that women should leave, but I would say a TVI approach would not make that assumption or try to encourage people to leave. But her income might change a lot during that, and it might be a barrier to making a decision to leave the relationship if that's what she wants. And then within the context of abusive relationships, coercive control and financial abuse are often featured. So, you know, instead of judging Elaine or being frustrated with her when she doesn't show up, you might want to, think about what are the barriers to her coming to your service, and are there ways that you can actually support her being able to receive the services you provide, to attend your education sessions, and to get something important that aligns with her priorities. So in the speech bubble there, it's just, some simple language that you can use that aligns with the TVIC principles in terms of having a conversation with Elaine. And this graphic is from our TVIC Foundations curriculum, which is available here. So because I can't do workshops and webinars every day, but sometimes it's more fun than the other things I do, like marking papers. We created this free online curriculum, so you can access it at the URL below. And it really sort of walks you through in a lot more detail, different examples and cases from different contexts, from school contexts to healthcare contexts, et cetera. We don't necessarily have a financial literacy education one, but I know Rebecca and team are working on that right now. But it is a useful resource for a variety of different disciplines to think about how to implement TVIC at these different levels. And that is what I have for you today. That's my email address. Please feel free to email me. We do have a handbook coming out with lots of case studies across some of the contexts that I've told you about, as well as some of the core concepts. Very practice-oriented handbook coming out hopefully this fall from the University of Toronto Press. And then the 2 web resources, equiphealthcare.ca and gtvincubator.uw.ca. Lots of resources, all free. Thank you.